Hi, everyone. I'm Dr. Aaron Farberg, a board-certified dermatologist based in Dallas, Texas, with my private practice, Bare Dermatology, as well as our dermatology residency program, the Lake Granbury Medical Center, coming at you on GPP Day. Let's go. What are the common triggers of GPP flares? Well, it's everyone's favorite treatment, systemic corticosteroids. Coming off those, withdrawing, yes, that's been a leading cause. Infections, pregnancy, rapid withdrawal of other drugs. Of course, there's tons of case reports of that. And then, of course, like all things somewhat related to psoriasis, stress. These are some of the common causes. Of course, if you have, genetic mutations or just, de novo, random stuff happens to these patients. And it's just an unfortunate disease. We can't always predict that and for who, what, when, and where. And so, it's always important to consider a full history when you're seeing these patients in your clinic to really determine the actual diagnosis if it is GPP. Things have changed significantly now that we have Spevigo available for the treatment of our GPP patients. And guess what? It's not new. It's been around for a couple of years now, and we have it for the acute phase, the flare. We have the injection, or I should say infusion, and then we also have the subcutaneous injection to avoid the flares, essentially prevent the flares. And again, we have so many patients with this chronic GPP that, they really need to be on this particular drug because, again, it's the pathway that's most active in this disease. We know it has the most impact when we treat this disease, which is an IL-36 disease, with Spevigo, because again, it's an IL-36 drug. As rare as GPP is, it's still a very unique mechanism, and so we love to study it and love to learn more. And of course, there are a few more developing treatments as well for it. Now, again, there's nothing that's commercially available, so it's all just, cross your fingers and hope that it all works. But imagine like when we were in the world of psoriasis and we had our first biologic available for that disease. And we thought, wow, this was life-changing. And Spevigo has been life-changing. There's always the hope that there may be the next drug that works even better, or perhaps, targets even further downstream in the inflammatory cascade and see if that could potentially work better. Again, it's all theory at this point. The clinical trials have to be done. Until then, Spevigo is a knock it out of the park win when you got to treat GPP. So one of the key things with treating GPP is a multidisciplinary approach. Of course, you have all the other doctors, unless they walk into your office and say, hey, I have GPP, it's collaborating with your colleagues in the urgent cares as well as the emergency room, and making sure that the patients are doing well systemically, and then making sure that you're able to get them on the right treatment. I think all too often, many of these patients are on other psoriasis biologics. And from my previous discussions explaining how IL-17, 23, and 36, yes, they do have various relationships with each other. You could imagine a patient that's doing okay on perhaps another psoriasis biologic. Maybe it was easier for you to get them on, or you had a sample of it in your refrigerator. But again, that's not the ideal treatment for these GPP patients. We know from all of the studies that the Spevigo is going to do the best when it comes to avoiding flares as well as obviously treating any significant flare. And so it's worthwhile ensuring that these patients can get on the right drug, switching them to the right drug to optimize their care.